Hello everyone, this is Seong Ho Han from St. Vincent's Hospital, the Catholic University of Korea. The topic of this presentation is MCPA. So, what is MCPA? MCPA is the acronym for Multipurpose C modified Palatal Appliance, which is typically used for Class 2 malocclusion correction and non-extraction treatment. As you can see on the right photo, MCPA is placed in the center of the palate, anchored by 3 mini screws, and has a right and left extension arms used with power chain to exert retraction force. As shown in these photos, MCPA can be used for maxillary total retraction. Entire maxillary dentition have been distalized in this photo for class correction. On the other hand, these photos show that MCPA can be used for retraction of maxillary molars and premolars, while keeping the upper incisors in their position. Because buccal segments were retracted, maxillary arch length has been increased for non-extraction treatment. This slide also shows the typical treatment effect of MCPA. The lateral cephs show that after the treatment, maxillary incisors become retroclined, and after the treatment, the nasolabial angle has been increased, thus reducing the lip protrusion. This presentation will include where MCPA comes from, its design and placement procedure, and its treatment effects. So first, its background. Where does it come from? Let's step back and remember that there are many different kinds of temporary anchorage devices available for non-compliant intraoral anchorage control. Mini screws are a good example of them. As you can see, mini screws come in different head designs, different diameters, varying length, different cutting designs as well. But they all share the common fact, that is, to be used effectively, they should be placed in interradicular space without touching adjacent dental roots, as you can see in the photo. But it doesn't always happen, and sometimes the mini screw can come in contact with the root and cause a serious damage. It gets worse. It happens that mini screws do not have to come in contact with the root surface to cause damage. Article published in 2011 reported that placing mini screws less than 1 millimeter from the root surface caused the root surface resorption. Knowing that, now it seems like using palate as a source of retraction force as an insertion site for the TADs sounds like a good idea, because now if we are placing TADs on the palate, we don't have to worry about damaging the roots or harming other important anatomical structures. Obviously, there have been previous attempts to use palate as a TAD insertion site. These photos show that palatal button with a sandblasted surface have been used in animal studies. As you can see, prosthodontic implants have been also used by certain orthodontic, periodontic, dual-trained specialists. Obviously, mini screws can be used on the palate as well. But as you can see in this picture, when mini screws are used on the palate with a resin like this, the gingival inflammation is more likely. And also, looking at the design of the appliance, you can see that the precise amount of force control and the force vector control and tooth inclination control may be very difficult. Now let's look at these photos for MCPA. You can see that it has simple, elegant design, gingival tissues clean, and during insertion process, you don't have to worry about the root surface or damaging other important anatomical structures. It also has different level of notch for more precise force vector control. Let's look at a case. 12-year-old female patient with a CC of a retruded chin presented herself to the clinic. You can see the patient has a lip protrusion, lip incompetence, proclined upper-lower incisors, mild crowdings, class 2 relationships. After 14 months of upper arch distalization with MCPA, upper-lower 19 by 25 stainless steel arch wires were engaged, and you can already see that her profile has improved significantly. After 33 months of active treatment phase, Class 1 molar canine relationships were achieved, overjet improved, patient's profile improved as well, and braces were removed after upper-lower 3-to-3 fixed wire retention. Treatment changes in lower third of the face and cephalometric image were shown. Superimposition of pre-post ceph image and cephalometric analysis showed that A and B angle improved by 1 degree. Upper incisors got retracted by 13 degrees. Overjet improved by 1.5 millimeters. Nasolabial angle also improved by 5.5 degrees. Upper lip retracted by 2.5 millimeters, while the lower lip retracted by 4.5 millimeters. These are 3-year retention photos. You can see that favorable changes brought by the orthodontic treatment has been maintained over the retention period. Next topic of the presentation is MCPA design and placement procedure. Earlier design of MCPA had 3 flat mini screw tubes or circles. Later, it was revised to include semicircular tubes covering only outside of the screw holes. Current design of MCPA include full circular tubes in tapering shape, and height of the tube is 2.5 millimeters with a 2 millimeter diameter for screw insertion. So if we are using 8 mm length and 2 mm diameter screw, it means that up to 5.5 mm of length of the screw may be inserted into the bone. Compared to the previous version of MCPA, the current version improved its design in 3 major areas. First, its material changed from stainless steel to titanium 4 alloy. Because titanium alloy is softer material compared to stainless steel, its maneuverability has improved. In other words, sometimes, let's say if the operator couldn't perfectly match the path of insertion among the 3 mini screws, now the MCPA has a greater chance of being successful and being so stable after insertion. Second, its design has changed from notch for the power chain engagement on extension arms to the hooks. Notch was not bad, but hooks obviously is easier for power chain engagement. Third, originally to anchor the MCPA in the palate, 3 mini screws with a dimension of 2 mm in diameter and 8 mm in length were recommended. But with the new version, now they are saying length of a 10 mm rather than 8 mm seems to be more adequate for certain adults. So the operator now can choose between 8 or 10 mm length mini screws. So where in the palate will warrant the highest success rate? There are 3 major factors to be considered, and the first one is bone thickness, which should be thicker. Bone density should be higher, and soft tissue thickness should be thinner for less inflammation. So where are such areas in the palate? First, the area in black represents relatively higher bone thickness, and the area in red represents relatively higher bone density, and the yellow represents relatively thinner soft tissue thickness area. So combining all 3 boxes, you can see this is our potential target area. And if you consider the biomechanics of MCPA, where the dentition should be distalized, then it is more advantageous to place MCPA more posteriorly than anteriorly. Thus, this green circle represents our target area for MCPA placement, and you can see it's at the level of the contact between the second premolar and first molar. With the proper installation, this is how the MCPA should look like in the palate, and you can see the center of MCPA is at the level of the contact between second premolar and first molar, and you can see 3 mini screws that anchors the MCPA is immediately at the paramedian region of the mid-palatal suture. Next, let's talk about the clinical MCPA placement procedure. First part of it is to adapt the MCPA plate to the individual patient's palatal surface contour. So after adaptation, there should be uniform distance of about 2 mm between undersurface of the plate and the palatal soft tissue. Once that's done, next part is to prepare silicone jig, which will guide the path of insertion during the mini screw placement. To place MCPA chairside, you will need implant engine, adapter, mini screws, and recommended RPM is between 20 and 30, and recommended torque value is about 30 to 40 Newton centimeters. For installation sequence, first, the palate will be injected with a lidocaine and cleaned with a hydrogen peroxide. Next, prepared MCPA with a jig will be positioned on the palate, and 3 mini screws will be placed one by one with the recommended RPM and torque. Once that's complete, the jig will be removed and retraction palatal arch will be cemented on upper first molars, and power chains will be engaged to exert about 300 grams of retraction force per side. Sometimes, after installation of the MCPA or during retraction with the MCPA, we can see the contact between the retraction arch and the MCPA plate, which interfere with the distalization movement. When it happens, simple solution is to get a high-speed handpiece and diamond burr and shave up the plate so that we can continue with the retraction treatment. Let's look at another case. 11-year-old male patient presented himself to the clinic with a CC of upper teeth sticking out. Pre-treatment record shows that there was proclined upper incisors, increased overjet, mild crowding in upper and lower arches, and class 2 dental relationships. After 4 months of treatment with the MCPA, already class 1 canine molar relationships were achieved and overjet was reduced. After 12 months of active treatment, upper dentitions were successfully retracted, overjet was reduced, and class 1 molar canine relationships were gained. This represents the treatment changes in profile and lateral cephalometrics. Superimposition of the ceph tracing and ceph analysis showed that A and B angle improved about 1 degree. Upper incisors become retroclined by 12 degrees. Overjet improved about 3 millimeters, while nasolabial angle improved by 7.7 degrees. Next, let's look at treatment effects of MCPA in more detail. In the literature, following are the changes reported after CBCT analysis of adult patients treated with MCPA. You can see A and B angle decreased by 1 degree, while the occlusal plane moved downward anteriorly by 2.8 degrees. Overjet decreased by 1.1 millimeters. Nasolabial angle increased by 3.2 degrees. Upper lip retracted by 1.1 millimeter, while the lower lip retracted by 1.5 millimeters. Also, upper incisors retracted by 2.99 millimeters, extruded by 1 millimeter, and retroclined by 6.2 degrees. While maxillary first molar crown distalized by 3.3 millimeters, root became distalized 2.17 millimeters, and intruded in crown level by 1.75 millimeters and 1.5 millimeter in the root level. As a net, upper first molar retroclined by 3.4 degrees. Second molar showed similar pattern, while its crown distalized by 2.6 millimeters, root distalized by 2.1 millimeter, intruded in the crown by 1.2 millimeter, in the root by 1.3 millimeters, with a retroclination of 2 degrees. Then, how about the age variable? Is MCPA equally effective for both adults and adolescents? There are two good studies to answer that question, each published in 2014 and 15. Adult MCPA group showed 3.3 millimeter distalization of upper first molar, while upper incisor retracted by 3 millimeters. Adolescent MCPA group displayed 3.1 millimeter distalization of upper first molar and 3.3 millimeter retraction of upper incisor. Conclusion: overall, MCPA effect seems to be similar across the different age groups. Next question. If MCPA is so effective in distalization of buccal segments and retraction of the upper arch, then is MCPA as equally effective as an extraction treatment approach? A study published in 2018 tried to answer that question. Let's first look at 4 first molar extraction group. Upper incisor retracted by 5.3 millimeters, lower incisor 4.1 millimeters. Upper lip retracted by 2 millimeters. Nasolabial angle increased by 9.6 degrees. Now let's compare that with the MCPA group. In MCPA group, upper incisors retracted by 3.4 millimeters, lower incisor 1.4 millimeters, upper lip retracted by 1.1 millimeters, and nasolabial angle increased by 5.5 degrees. Obviously, there was significant difference between the two set of numbers, but trends were the same. But also clinically, you look at the cases. Can you tell which one is an extraction case or which one is MCPA retraction case? Well, some of you probably already figured out the answer, but the answer is the upper case is the first premolar extraction case, and lower is the MCPA retraction case. But the point is, clinically, the difference may not be as big as what it seems on the paper, and MCPA may be a good treatment approach for some patients to avoid 4 first premolar extractions. Next question. Does presence of the third molar impede distal movement by MCPA? In other words, do we have to extract third molars prior to MCPA therapy. In 2016, interesting 3D finite element model analysis study was published to look at the effect of unerupted third molar germ in the upper arch in distalization facilitated by MCPA. If you look at stage 2, there was absence of a third molar. In stage 3, third molar was present. And only difference between stage 2 and 3 was the absence and presence of a third molar. This is the results of the study. And we will compare between stage 2 and 3 only. As you can see, dental movement pattern between stage 2 and 3 in all 3 dimensions were precisely exactly the same, which suggests whether third molar germ is absent or present. Maxillary dental movement patterns are the same. They are unaffected by it. Therefore, the conclusion was the presence or absence of a third molar follicle showed no significant effects on MCPA-aided dental movements, according to FAM. Here, some of you may think, wait a second, FAM model only explains the early initial phase of dental movement. Well, that is correct. So let's look at it in a different way. This is part of the adult CBCT study results. As you can see, the adults group were divided by third molar extraction group and third molar present group. And you can see all across the board in terms of dental movement, there was no significant differences between the two groups. Therefore, presence of a third molar did not affect or change the dental movement treatment results. Therefore, conclusion of this presentation is the modified C palatal anchorage plate is a simple, effective, efficient, and yet versatile appliance that can be used for correction of class 2 malocclusions. There is a textbook about MCPA for non-extraction orthodontic treatment. It has a lot of fresh information because it just published this year. For those who want more information on MCPA, this is the book I would recommend. I thank you very much for your attention. Should you have any questions regarding this presentation, I can be contacted at this email address. Thank you very much.